Super. Thanks, Amy. And
Just
thanks
real quick,
for
I'm
the,
sorry. If I could get everybody, if you're not muted, to go ahead and mute yourselves so that we can hear Dr. Lee clearly. Thank you.
super. And I guess, Amy, if you don't mind, if there are questions that come through, if something comes up, if there's any questions in the chat, if you could monitor that, and feel free to interrupt me, and I'm happy to address it.
I will definitely do that. Thank you. Again, everybody, please go ahead and mute yourself. Thank you.
Well, yeah, my name is Juan Lee. I am trained in pulmonary critical care and in sleep medicine. I have seen a number of patients with multisystem atrophy relevant to sleep and breathing related disorders. And my goals today is to go over a number of things that are relevant to sleep and breathing for MSA. We know that MSA is a complex disease with diverse symptomology, from autonomic dysfunction to mood and motor disorders, but sleep is also a integral part actually in the diagnosis and evaluation of longitudinal symptoms for patients with multisystem atrophy. And so it does take a comprehensive care team, interdisciplinary team, and certainly we want to be patient-centered. This is an article from Daniel Klassen. It was a nice kind of overview about MSA. So what I'd like to go over is the prevalence of sleep-related disturbances in multisystem atrophy, and describe some of the common sleep disorders that we see, either fragmented sleep, REM behavior disorder, or dream enactment is something I'll spend a fair amount of time about, as well as daytime hypersomnolence, so daytime sleepiness. Some of the breathing disorders that have been associated and implicated with MSA include obstructive sleep apnea, central sleep apnea, and then stridor, both nocturnal and daytime. I'll go over treatment options, particularly from REM behavior disorder. It segues very nicely with the most recent updated guidelines from the American Academy of Sleep Medicine that was just recently published. So I'll update the audience on that. And then I'll also integrate some recent data and statements on management of sleep-related breathing disorders in MSA. So this is a study from Italy, and what they did at the beginning part of the study is they did a overview of epidemiology of sleep disturbances in patients with MSA, and they did a review of some studies from Italy and from the early 2000s and the late 1990s, and they got this data mostly from Sleep Disorders Questionnaire. So what they found is that 70% of MSA patients had complaints of sleep disorders, which is a significantly high percentage. And what that consisted of included sleep fragmentation, waking up throughout the night, early wakening, insomnia, either difficulties falling asleep or staying asleep, and manifesting with about 50% of patients having excessive daytime sleepiness during the daytime. And when analysis of polysomnography data, which is a sleep studies have shown a variation in what happens and what is seen in patients with MSA, either reduction in a stage of sleep we call deep sleep, which is a very restorative sleep. So that has been shown. Increases in light sleep, which would make sense with the sleep fragmentation. But overall, it showed that there was an unchange in REM sleep or dream sleep. So it was very interesting that overall, there's just a slight reduction in deep sleep and an increase in light sleep, but overall REM was relatively preserved. What they described was various respiratory abnormalities that occurred during sleep, including nocturnal stridor. And I'll talk about that a little bit later on in my presentation, but the prevalence of this was from 13 to 69% of patients with MSA. Obstructive sleep apnea, prevalence of 15 to 37% of patients. Now, I'll take a side note. It's unclear if MSA itself is a risk factor for obstructive sleep apnea. It might be, But we just know from prevalent studies whether or not obstructive sleep apnea is a part of MSA or if it's an innocent bystander because it happens in older adults and patients. And so general population, this is actually a very similar epidemiology rate. Restless leg syndrome in 28% of patients, which is an urge to move legs. And in this study, an analysis of older studies is REM behavior disorder was described in 90 to 100% of MSA patients with sleep study confirmation of REM behavior disorder. And I'll touch on this about how important having a American Academy of Sleep Medicine certified sleep center do a sleep study to confirm the presence of REM behavior disorder. So why are there sleep disturbances in MSA? And I'll just read this. This is from a neurologist who's trained both in neurology and sleep medicine for Mass General. And in his article, he wrote that the pathophysiology of sleep-wake disturbances in Parkinson's disease and MSA remain largely unknown, but the etiology is likely to be multifactorial, including the impact of motor symptoms on sleep, adverse effects of anti-Parkinsonism medications, and neurodegeneration of sleep, of central sleep regulatory areas. So it may be motor, maybe side effects of medications, and the impact of the disease itself from the neurodegeneration. So this is an article from the United Kingdom about REM sleep behavior disorder. So REM sleep behavior disorder is actually a relatively recent diagnosis that was first described in 1986 by Carlos Schenk, who is a sleep expert in Minnesota. And his group were one of the first groups to recognize REM behavior disorder, and then also were the same group that recognized that it may precede a diagnosis of a neurodegenerative disorder. So what they found is that a decade after patients had these symptoms of REM behavior disorder, they were diagnosed with Parkinson's disease. And he also wrote about the high prevalence of REM behavior disorder in 25 to 58% of Parkinson's patients, and up to 90% in those with dementia with Lewy body or multisystem atrophy. And so Schenk is really credited as one of the main researchers who identified this disorder and made that link of the prevalence of this in patients with neurodegenerative diseases. So what is REM behavior disorder? So what happens is it is a REM phase associated parasomnia. Parasomnia means doing something at nighttime or during sleep that normally you wouldn't do, such as sleep eating, sleep talking, sleepwalking. And so the parasomnia in this case is actually acting out dreams. Dream enactment is sometimes what you'll hear from sleep physician trained practitioners. It is normal in REM to have normal muscle atonia. And what that means is when we go into these cycles of REM sleep, we normally should be paralyzed. And the only muscles that really should be active include our eye muscles, which is the term rapid eye muscles, and our diaphragm, which is important for respiration and breathing. And what we find is in patients with REM phase associated parasomnia is we find evidence that the muscles are not paralyzed during REM. And that actually is abnormal. And the reason why that's abnormal is when we're dreaming, typically our body is paralyzed so that we're not acting out or really moving during the dream, which one can imagine can be very vivid and very active. And so the dream content occurs during REM behavior disorder is often violent, unpleasant, or action-packed. And some of the descriptions on this other point are, and patients have told me this, dreaming of being chased or being attacked or defending their partner from an attack. And therefore the behaviors include either hitting or kicking, even attempted strangulation with screaming, shouting, or even laughing. And I always have observed this, that the dreams can be very kind of disconcerting for the bed partner. And I've always wondered, why are they dreams that are not pleasant, like planting a tree or doing some gardening? But it's very interesting that it's a lot more of a violent or unpleasant dream. And so what's interesting about this is the sufferer usually doesn't recall the content of their dream. They usually don't remember it unless the person is woken it up during the dream. And then they have very vivid recall of their actual dream. What's also interesting and important when we think about REM comes into 90 minutes of phases. Every 90 minutes we go into REM, and our REM periods typically get longer throughout the night. So our REM period at, say, early in the morning between 3 and 6 a.m. is going to be much longer than the REM period maybe around midnight or 1 o'clock. And so a lot of these activities, sometimes you hear from patients will tell us it's late in the sleep period, maybe closer to early morning. So the timing of it is sometimes gives us even more evidence or suspicion that this activity is happening during REM. Not surprisingly, RBD is associated with significant physical comorbidity incurred either to the individual or onto their unfortunate bed partner due to injuries from falling out of bed or the sufferer directly striking their bed partner. So I remember one of the first patients I saw when I was a sleep medicine fellow at the University of Chicago was a patient who came in, and he looked really bruised up, and and I said, well, what's the main complaint from a sleep perspective? And he said, well, I have rib fractures. And I said, well, we're not a trauma clinic, we're a sleep clinic. And he said, no, what I've been acting out my dreams. And the most recent dream he had was where he remembered that he was being chased by somebody, and he ran out of bed and then tackled, he thought, the person who was running after him, but he actually tackled his dresser, a large dresser, and then the dresser fell on him and then fractured his ribs. And so that's why we saw him, is because that was his first episode of dream enactment or REM behavior disorder that we saw. So frequently, the physical comorbidity can be quite significant. So when we diagnose REM behavior disorder, number one is we need to have a clinical history. So a lot of times the patient or the sufferer doesn't really know what happens. All they know is something happened where they fell out of bed, or they may have hit the dresser next to them. They don't sometimes know exactly what happens, but really getting the history from the bed partner is very, very important. So clinical history. And then number two, according to American Academy of Sleep Medicine and a lot of experts in the field, we should do a sleep study, which is a polysomnogram or polysomnography. And we get a lot of information. We get EMG, which is not painful when we do this. And what we're showing is the loss of that muscle paralysis. This is a term we'll write in our sleep study report, loss of atonia, which means the loss of that natural paralysis, which is something we can pick up. EEG is important because then we have to confirm that activity, if they do act out their dream, is occurring during REM sleep. We have video in case we capture any one of the dream enactment episodes that we could correlate with REM sleep, that we can, yes, for sure, correlate the timing. And then airflow monitoring to exclude obstructive sleep apnea, and central and obstructive. Now, a lot of patients with RBD can have sleep and breathing disorders that I talked about. But in that same case I talked to you about, that first patient I saw with dream enactment, when we actually did the sleep study, he actually had obstructive sleep apnea. And what's very interesting is obstructive sleep apnea occurs worse during REM sleep. We actually ended up diagnosing him with something pretty uncommon, which is called pseudo REM behavior disorder. He had obstructive sleep apnea that woke him up during REM, and therefore he was sort of in a confusional state. And when we actually treated his obstructive sleep apnea, his dream enactment completely resolved. And that's why it's very important to do a sleep study because I think it really helps to tease, is there something else that could be triggering these activity during REM sleep that might not be the classic REM behavior disorder that I'm talking about? The other thing that we want to make sure is it's not a seizure, because sometimes there can be movement that is actually not REM behavior, but is a manifestation of epilepsy. So the sleep study can be very, very helpful as far as clinching and making sure the diagnosis is accurate. So like I said here, seizures, pseudo REM behavior disorder, and it could be an alternative diagnosis. So this is pretty much a statement about how to set up your sleep study, video polysomnography, to optimize capturing REM behavior disorder. Because unfortunately, some sleep centers may actually miss this diagnosis because they may not set up correctly to anticipate that this could be the diagnosis. So this statement really helped a lot of sleep centers to sort of think about how they can change their policies and protocol to make sure that they're capturing this kind of diagnosis. I also was surprised to find that there's an international REM sleep behavior disorder study group. And so there's a number of people who specifically are interested in research in REM behavior disorder, and a number of them probably contributed to the most recent updated guidelines relevant to treatment of this, which I'll come to a little bit later. Another finding I found in the MSA Coalition website about REM sleep behavior disorder, again, because the prevalence is so high, 90 to 100% of patients, I was grateful to see that there was a link about symptoms and recognition and treatment. This is from the same investigator from Mass General about managing sleep disorders in Parkinson's disease and MSA. And he also went over some of the other disruptions that occur that I'll come back to about insomnia, circadian rhythm disorders, even restless leg syndrome. So this is the most recent updated guidelines in the Journal of Clinical Sleep Medicine from the American Academy of Sleep Medicine that was just published this year in 2023. The senior author is from the University of Minnesota. This is the same place that Carlos Schenk has been. And so these are a lot of experts in the field of sleep neurology. And they gave us updated guidelines on how to manage REM sleep behavior disorder. And the first important thing that they talked about was about safety of sleep environment, safety first. And so I'll just read this to you. It is critically important to help patients maintain a safe sleeping environment to prevent potentially injurious nocturnal behaviors. In particular, the removal of bedside weapons or objects that could inflict injury if thrown or wielded against a bed partner is of paramount importance. Sharp furniture like nightstands should be moved away, or their edges and headboards should be padded. To reduce the risk of injurious falls, a soft carpet, rug, or mat should be placed next to the bed. Patients with severe uncontrolled REM behavior disorder should be recommended to sleep separately from their partners, or at the minimum, to place a pillow between themselves and their partner. So I think they know as well as we do that safety first. I've talked to my colleagues in epilepsy, and for their seizure patients, sometimes they'll recommend that the patient only sleep on a mattress that's on the floor and take out the box spring or any type of supporting structures, because if the patient were to fall out of bed, it would only be about 6 inches or so instead of a much higher fall. And to being very careful about objects that are also in the bedroom. You don't want to have, again, like a large dresser drawer that could lead to orthopedic injury. So this is what they had as far as medication recommendations. And you can see all the check marks here as far as approved for. So I'll focus on secondary RBD due to a medical condition, because that's really what this talk is about. And the medical condition here is MSA. And so the recommendations were for clonazepam, immediate release melatonin, as well as rivastigmine, which is a anticholinesterase inhibitor medication, which is used for memory impairment, that seems to have activity for REM behavior disorder due to medical condition. They recommended against deep brain stimulation for REM behavior disorder symptoms. And so this is commonly used for Parkinson's disease. Although I would argue that if a patient has very severe uncontrolled Parkinson's disease, what I have seen is the utility of the deep brain stimulator actually helps the sleep fragmentation if the sleep fragmentation is due to uncontrolled Parkinson's symptoms. But in this analysis, what the investigators were asked to do is to look specifically at REM behavior disorder symptoms. And the evidence does not seem to support that the placement of the deep brain stimulator helps with REM behavior disorder. The other important thing is some medications can actually induce REM behavior disorder. So that's something to think about. SSRIs, which are a class of medicines used for depression, medications like Paxil or Prozac or Zoloft, can actually cause REM behavior disorder symptoms. So it's always very important to review medications with your neurologist, and you might want to explore whether or not if there's dream activity symptoms, it might be due to a medication. So the final recommendations that they had was clonazepam for the treatment of secondary REM behavior disorder. I wonder if any patients are on that now. Immediate release melatonin, which can be very effective. And what we found with melatonin is sometimes we have to go to very high doses, sometimes up to 10 to 15 milligrams of melatonin to help to decrease the severity of REM behavior disorder. Transdermal rivastigmine, so it's a type of skin patch that has been studied and can be effective in reducing REM behavior disorder, and then not using deep brain stimulation. The other medication I will mention is in isolated REM behavior disorder, which means not associated at the time with a neurodegenerative disease, about the use of pramipexole. I've had a number of patients that I've used pramipexole, which is Mirapex, which is used, it's a dopaminergic medication, which is used for restless leg syndrome, it has been used for Parkinson's. I have seen favorable response in reducing REM behavior disorder. So that might be something that's an overlap for patients who have Parkinson's disease who are taking this medication. So benefits and side effects, clonazepam from doses of 0.5 to 2 milligrams has been shown that 90% of patients report partial or complete remission of REM behavior disorder. It reduces phasic REM, but the problem is it can lead to sedation and sometimes daytime sleepiness. And certainly in patients who have motor dysfunction, unfortunately, it can increase the risk of falls or contribute to confusion. However, you always have to be very careful as far as balancing benefits versus risks. If the patient's able to clear this medication, or if you're able to find a sweet spot of a lower dose medication, this might be just as effective to reduce and not lead to side effects in the day. As I mentioned, melatonin has been studied. And so one small study showed 50% of improvement in RBD symptoms. As I said, it's higher doses of melatonin. The problem being morning sleepiness and headaches. And also the other problem is it's not regulated tightly by the FDA. And therefore, there have recently been a lot of calls of concern about melatonin, about the actual efficacy of the medication, because it may not be regulated, and therefore the actual amount of melatonin may not be as what is actually written on the bottle. So unfortunately, because of lack of regulation for melatonin, sometimes it's unclear the actual efficacious dose. I will tell you that from clinical experience, we have had a lot of success with melatonin reducing REM behavior disorder. And I think it's actually sometimes even more tolerated compared to clonazepam. Other sleep disorders to think about in MSA, so restless leg syndrome, an urge to move your legs, which can happen. Excessive daytime sleepiness, and that could be for a variety of reasons, either side effects from medications or poor sleep quality. And modafinil, also known as Provigil, can be very effective as far as helping daytime sleepiness. And then sometimes we'll see circadian rhythm disruption, particularly patients who have delayed sleep phase syndrome, where they go to bed late and they wake up late. And so for them, instead of using it for REM behavior disorder, melatonin, we're using to help reset their circadian rhythm. And that sometimes will couple with exposure to blue wavelength light, which is wake promoting in the morning, to try to help reset their time frame. And then sleep disordered breathing is obstructive sleep apnea, which is use of a CPAP, continuous positive airway pressure. Central sleep apnea, which can be recognized in patients with MSA, we'll have to use a different type of non-invasive breathing device called a BiPAP or an adaptive servo ventilation. And then nocturnal stridor, which I'll touch on at the end here. So complications, this is a article that was written from a group in New Mexico. And so they talked about obstructive sleep apnea, central sleep apnea, and stridor. So obstructive sleep apnea, as I said, is very common in the general population, but it does seem to, that in some studies have seemed to align with severity of MSA disease, and so might be a consequence of or impact of MSA. And some patients with MSA may have or develop respiratory muscle weakness. And that respiratory muscle weakness may also lead to weakness of the structures that keep the airway open. And in obstructive sleep apnea, the pathology is that the tongue falls back and occludes the upper airway. And so if you have weakness from MSA, you might see a higher prevalence of obstructive sleep apnea compared to the general population. Another interesting observation is central sleep apnea. Central sleep apnea simply means that the brain signal to tell your body to breathe may not be as effective. And so this is drawn about questions about MSA involving parts of the brain of the medulla, which is very involved in respiratory regulation, might be damaged with neurodegeneration seen in MSA. And so if that gradually deteriorates, it is very possible that patients may have central sleep apnea. And again, I come back to, it's important to recognize this prognostically, this might be a concerning feature. And number two is it's also important as far as what type of breathing device we want to put the patient on during the nighttime to help them breathe. So recognizing central sleep apnea and distinguishing it from obstructive is very important. The last thing this article touched on was stridor. Stridor is a paradoxical closure of the vocal cords. The vocal cords is basically our wind box that helps to regulate our voice, and also helps to avoid things like bacteria or secretions to go into the airways. So patients with MSA can have neurodegeneration that actually leads to dysfunction or discoordination of the vocal cords. And that can lead to a very high-pitched noise, a stridorous noise, a noise that sounds like a during breathing, during inspiration. And so sometimes we'll use a device called the CPAP, which is used for obstructive sleep apnea, that may help stabilize the upper airway. And sometimes we have to use a tracheostomy, which is a surgical hole in the neck, which is inferior or below the vocal cords, because that allows airflow to go into the lungs. Because if the vocal cords above are closing, then at least you have a conduit to allow air to go into the lungs, which is very important. So stridor caused by laryngeal dysfunction leading to narrowing of the rhemoglottitis. It's common in MSA. It's related to cell loss within the brainstem nuclei that modulate respiratory drive and resulting in dysfunction of the bulbar and diaphragmatic muscles, vocal cord dysfunction. We can diagnose it during a clinic visit because sometimes this happens during the daytime by the bed partner who's observing it at nighttime, or audio recording. And so in this study, Can You Hear Your Patient Sleep? This was giving some examples of using the smartphone to be able to record stridor. Let me see if this works here. Here we go. It's very rhythmic, and it's during inspiration. And it's different than a snore. The actual frequency of the sound is very different than a snore. It's a higher pitched rhythmic
Hey, Ron,
during
I don't think
inspiration.
we can hear it. I don't think the
Oh, you can't?
video sound is not
Oh,
coming through.
oh shoot.
So
Sorry.
you'll
Sorry, Steve.
you'll have to fake it yourself.
I'll have to demonstrate it. Okay, I'll do it myself. Thanks, Steve. But it's really a high pitched very rhythmic. It's during inspiration. Very different than a snoring. A snoring sound is more of a lower sounding, lower frequency, lower power sound. And Strider is just a very different type of sound, and important to distinguish. And that's why this study, what was really nice about it, it was just a good reminder of utilizing technology and a smartphone. And I'm sure Steve's the same, is that when you play this, it's very, very descriptive, and we can really distinguish snoring versus Strider.
Sorry to interrupt, but is it helpful for you for family to take a recording and so you can hear what it is? It helps me to say, hey, they're making a lot of noise, and they have a recording, we can hear what it is.
Yeah, absolutely. Because it does, because sometimes I have seen where people thought it was Strider and it really sounded more like snoring. But if it's Strider, I'm moving a little faster about an intervention. I'm thinking, I think I should get them into the sleep study and then start to think about treatment options that we can offer. And I think it ties in pretty nicely into this statement from Neurology in 2019. When I would co-manage patients with Steve through the years, we would always get very worried about Strider. That patients, and unfortunately, there are stories about patients who would have sudden death in the middle of the night. And what happens in Strider is there is a closure of the vocal folds. And one can imagine if those stay closed, there's inadequate air that goes into the airways. And for a long time, we were very worried about this. So this was an important statement that was convened in Italy. And these experts got together and evaluated data, existing data, regarding what types of treatments, prognosis should we think about if somebody presents with MSA and Strider. So I'll just highlight some of the important things here. Strider is suspected, the high-pitched breathing sound that we talked about. Now, it also can occur during wake as well. So that's one thing. It can progress. It's under-recognized, but I think in the with adequate health literacy and education, bed partners should be aware about this. Should be encouraged to audio record episodes, just like what Steve talked about. They talked about that sleep studies may be able to help to delineate this. I think is very helpful. Where this is very helpful is then we really engage our partners in otolaryngology. And fortunately, we have a laryngologist who's really amazing, Leslie Childs, that has expertise in Strider and recognizing this. And so first is they'll need to do a laryngoscopy because it could represent something else. It could be a lesion, a vocal cord lesion, or something else that's leading to that high-pitched sound. So that's an important thing to exclude. And then oftentimes Dr. Childs can make the diagnosis just by looking at the vocal cord movement during the laryngoscopy. Now, they may not have the classic symptoms during the daytime. And so another intervention she can do is do a drug-induced sleep endoscopy called DICE. And what's helpful for that is because some of these sounds only occur during nighttime, and she can then also look at it and see what the motion of the vocal folds are, what's occurring during the nighttime. But the big important thing is what should we do for these patients? Well, let me just, before I talk about that, is the big question about survival. And so this is great when the panel of experts looked systematically at existing literature. Whether Strider affects survival is uncertain. It's uncertain. Strider within 3 years of motor or autonomic symptom onset may shorten survival. However, I identification of stridor onset may be difficult. Whether specific features of stridor affect survival remains to be determined. And stridor during wakefulness is widely considered to reflect a more advanced stage of the disease than stridor occurring during sleep. And I think the important thing, and I'll kind of come to it, is that my analysis is that these patients who had sudden death at nighttime, it may be multifactorial. A part might be breathing related. It might be autonomic related too. So it might be a little bit more complicated than just an anatomic issue. So I think the jury's still out on if stridor alone is a poor prognostic indicator, and whether or not it might be a marker of more advanced disease of MSA, and therefore it might be a marker that there may be more degeneration of the autonomic system, and that combination of cardiac implications and breathing implications might be what's really driving the sudden unexpected mortalities that unfortunately can happen. But as far as treatment, the same neurology article summarized a lot of options. For a while, a lot of us thought that tracheostomy would be the safest decision. And the thought process is, again, is if the vocal cords close, if you had a tracheostomy, which was a surgical hole in the trachea below the vocal cords, then the patient would still be able to breathe. And in some cases, that seemed to be effective to allow the patient to ventilate. But what they also highlighted is even patients who had tracheostomy had sudden death and in the middle of the night. And so it did beg the question that it might not have been, if you effectively had an alternative airway, that it could be an autonomic issue rather than an airway issue. Now in 2023, we often offer some sort of non-invasive CPAP therapy that can be very effective and attenuate the stridor sounds, keep the vocal cords open, and since so many patients have coexisting obstructive sleep apnea, also help consolidate their sleep as well. So in the statement paper, they said ventilation during sleep with CPAP can be useful in the symptomatic control of stridor. So they ultimately said, consider ventilation during sleep. Tracheostomy bypasses the upper airway. It is effective in control of stridor. So I'm not saying that you shouldn't consider it, because stridor itself can be very distressing to the patient. So it's something that we do keep as something to consider, weighing the pros and cons about this type of surgery. Whether CPAP improves survival in patients with MSA with stridor is uncertain, really hasn't been studied, and tracheostomy might improve survival in patients with stridor. But again, even in the pros, it was clear that there were still cases where tracheostomy wasn't definitively effective in improving survival. So overall, I would say our practice is still to think about doing a sleep study, talking to and working with our laryngologists, considering CPAP therapy, and keeping tracheostomy in our back pocket as an adjunct therapy should we need it for quality of life or even for safety purposes. But with a careful discussion about pros and cons about it. The other thing that we can also identify sleep-related hypoventilation and hypercapnia. As I mentioned, that multisystem atrophy can have motor weakness or muscle weakness. And so therefore that could impact gas exchange. But the thought here in central sleep apnea is it might be neurodegeneration at some of the central chemoreceptors, helping a patient to breathe. And so what this study highlighted is that you can have, all of these are different patients, is that you can have obstructive sleep apnea depicted by these different blue, red, and yellow, orange colors here. But what they showed is that a different type of modality in these circles can pick up something called sleep-related hypoventilation, which is a patient not breathing and having shallow breathing and therefore leading to elevations in carbon dioxide. And so this is not as classic and can be sometimes very difficult to recognize. And I draw your attention to one of these patients, this patient number 30, who has very mild obstructive sleep apnea, but had carbon dioxide levels that were in the 58 range. Normal is 40. So clearly there was gas exchange problems and inadequate ventilation that was occurring during the nighttime. And if a well-seasoned sleep practitioner is not in tune to picking this up, you might end up not ventilating this patient, which you can do with something called a BiPAP device or an adaptive servo device that would actually help their quality of sleep and quality of life and breathing. So something, again, to think about for doing a sleep study. And how this can be depicted is just an elevation in carbon dioxide levels that can happen during the nighttime. This is, again, about the mechanisms and prevention of sudden death. This is from a group in Japan. And overall, there was discussion that could this be representative of vocal cord dysfunction or stridor? Could it be autonomic dysfunction? It was really difficult to tease, or was it a combination? And so ultimately, that is really what is of concern. Now, one thing I will caution, and why I think it's very important if you're going to initiate CPAP, I did talk pretty highly that CPAP could be very helpful. And on the top here, you can see that the mask is placed on the patient's nasal area. And what this is doing is it's providing positive pressure. And so it's really helping maintain the airway, which is good. This is what you want to see. Now, in some patients, they have a very floppy epiglottis. Epiglottis is a tissue that protects the vocal cords and from you choking on food. And paradoxically, what unfortunately happened in this case is the airflow pressure actually pushed this epiglottis down and further closed the airway, therefore making it harder to breathe. And what the figure shows is that there's just a sliver of air that's going in. So when we're thinking about patients and putting them on CPAP, if the patient says, I am doing a lot worse, or my stridor is worse, or I am struggling to breathe even more with that device, then I've got to really think maybe I need to send them back to Dr. Child or an ENT expert to delineate the type of anatomy that they have. And I can imagine we might even do a drug-induced sleep endoscopy to see images like this that might prove that this is not a good modality. So I'm not going to say that CPAP is recommended for everybody. Certainly if patient's stridor feels better, their sleep fragmentation is better, they feel better in the daytime, stridor sounds less frequent, that's all thumbs up. But if things are not going well, then I think we have to pivot and think about alternative options here. So overall, I hope that you had an opportunity. I certainly learned a lot in review of this literature. There is a high prevalence of sleep-related disturbances in MSA, manifested as fragmented sleep or REM behavior disorder and daytime hypersomnolence. There's a number of breathing disorders that have been implicated with MSA, and doing a sleep study or a comprehensive evaluation, including ENT, is important. There's updated guidelines for management of REM behavior disorder. I always counsel our sleep medicine fellows, and when we see a patient with REM behavior disorder, that we may not be able to completely cure it or treat it 100% effectively, but if we can decrease the frequency or severity of symptoms, we're making some improvement in quality of life and trying to avoid excess medications that can cause side effects. So we have to try to be very pragmatic in our goals of care when we're managing this. And there's a lot more data. And I think we're going to even learn more as recognition of this disease and coexisting sleep and breathing and nighttime mortality is studied even more. So thanks so much for the opportunity to speak, and I'm happy to field any questions.
Thank you, Juan. It's very interesting. And I think that particularly the point about the sort of our thinking about stridor has changed over time. And I remember, not a lot, but a couple of patients who've had stridor from early on in their course, even daytime stridor who haven't seemed to do any worse than anybody else. It's one of those things that can be part of the early presentation or part of the late presentation, or sometimes they never really have much in the way of stridor in MSA.
Yeah, great point. Yeah.
Go ahead. We got a question on the deal in the stridor, and I'm the caregiver for Leilani. A lot of times I notice that on the stridor, it's only happening when she's on her back. It's not when she's on the side, it's only on the back. She mostly sleeps on the side, but when she falls asleep, watching television or whatever, this is, when she's on her back, it comes through, or even on the couch.
But I wake up because I can't breathe and I'm going.
But I do hear the sound that you're talking about.
Yeah. Well, certainly the positional component, the only way definitively, scientifically, would be to put her to sleep and do a laryngoscopy, a drug-induced sleep endoscopy, and sort of see anatomically what's collapsing or what's happening at either the vocal fold or the retinoids above it, or it could be the epiglottis that could be unstable in the supine position. And when you put her on the side, that might help to relax the vocal cords so that they can then work normally. I'd have to defer to something like a drug-induced sleep endoscopy or a laryngology evaluation. And then for our standpoint, we would still offer something like a CPAP. I don't know if that would be an option to see if, when you're on your back, if that airflow does help to maintain the patency. But you are exactly the person that if I put you on CPAP and you feel suddenly a lot worse on your back with it, then I would worry about that floppy epiglottis phenomenon, and then really want to understand the anatomy collapse. So there's something unusual about the supine position. Now, it's not uncommon that we see that with obstructive sleep apnea, a different disease where the tongue falls back and then collapses the upper airway. So we see that a lot with obstructive sleep apnea, a very positional component, but something about gravity and the structure stability seems to be even more compromised. And I think a thorough investigation. The simple, I wouldn't say simple, but the easiest thing is if there's a way to consistently have you off your back, which is easier said than done. I mean, unfortunately, patients that we recommend that they can start to have orthopedic complaints, shoulder or hip complaints when they're on their side all the time. So, and a lot of people just naturally like to sleep on their back or lay on their back. So that can be very challenging. So, but certainly a very distressing feeling. And I think a consideration of seeing one of our ENT colleagues or even a sleep expert to see if a CPAP might be helpful for you is warranted. But certainly something about gravity is unfortunately working against you.
But when she sleeps like that, usually, because we've got a reclining bed, so she's probably, she's not sleeping flat, so she's up a little bit.
It's the part where I wake up and I still cannot breathe. I'm still going, and I'm having to wait for that to relax so that I can breathe. I know it's coming at some point. I'll be able to breathe fully. But and I've had the sleep pack done and I couldn't tolerate it, the CPAP. So, and I have autonomic failures, so that's probably what is adding to it.
Yeah. Well, and the other group that I failed to mention was the speech therapists who might have some breathing exercises that might be very helpful in those episodes. So it might be something again to relook and discuss with our ENT colleagues if there's some breathing exercises that might be able to help you in those times. Certainly distressing, and it's really hard. I mean, we see a condition called vocal cord dysfunction, and that's similar with a similar stridor presentation. And one of the important things is relaxation during that time. But it's hard to relax when you feel like you have no air going into your airways.
That's what I try to do, but I know it's coming.
Yeah. the most effective exactly is to calm your breathing, because then that type of spasm or adduction starts to relax. But it's very difficult when you feel like you're not getting air. So it might be worthwhile to revisit that with the speech therapist.
Okay.
Thank you.
Steve, unless you have any other thoughts or suggestions.
No, I think that's right. I was
Yeah,
just going to say that if that's something you want to pursue, just let Amy know. We can start working on scheduling those things.
Okay, thank you, Dr. Green.
Dr. Lee, this is Bob King. My wife Diana is the patient, and she has some of the REM disorder where she talks a lot. She used to act out a lot more, but now she just talks a lot. And you mentioned Prozac. Does Prozac add to that? And if so, is there an alternative to Prozac? Because she's on Prozac as well.
Yeah, I mean, Steve would probably have more experience with it. This is so interesting. I think sometimes we see the REM behavior disorder sort of peak, and then it sometimes as patients have it longer, the activity starts to attenuate, right, Steve? I mean, would
Yeah,
you
that's right.
make that
Yeah.
same observation?
Some people even say, oh yeah, they were very active dreamers years and years ago, and by the time they really get to the diagnosis of MSA, that's pretty much gone. But it was clearly there by history in the past.
Yeah. But as far as the question about sleep talking and Prozac, I have to say I've never looked at that association. I'd have to look into the literature on that. But where we see it is the literature of SSRIs and REM behavior disorder. So that's really the action here. And sleep talking is within a normal purview. People can have that. So that's we see that in a general population. The only way to know would be to weigh the pros and cons about Prozac. Now, there are other antidepressants like Wellbutrin that doesn't have the effect strongly on the serotonin pathway. And that could be a consideration to talk to your prescribing physician about, is it worthwhile to give Prozac a holiday and try another class of antidepressant, and then monitor the symptoms of the sleep talking. A lot of times I'm pretty pragmatic. I would say sleep talking, really, I don't think it's really that bothersome, unless you're having some conversations that might go a little too deep. But otherwise, I think that that would be the only offer, is to look at a different class of mood stabilization like Wellbutrin to see if that would help to decrease it. But if it's really not bothersome, sleep talking, somniloquy is the other term that we use. I overall think that's a relatively benign condition, in my opinion.
And that by itself really doesn't meet the criteria for REM behavior disorder, sleep or dream enactment behavior. And again, a lot of times we wouldn't treat that unless, needed to for some.
I agree. Yep. Totally agree. Yeah. And unfortunately, some of these medicines, like even melatonin and clonazepam, we end up unlocking more side effects that are actually problematic for patients. So in REM behavior disorder or any type of dream enactment, we're pretty careful about things. And either fortunately or unfortunately, I think as long as the movement isn't causing any harm to you, Mr. King, or to your wife, that's actually a favorable thing right now. So it might be an innocent bystander that you might just want to monitor for now.
Okay, thank you very much.
Yeah, good question.
Anybody else have any questions? If you'd like a copy of the recording from today, just send me an email. I'll be happy to send you the link. Dr. Lee, thank you very much. This has been very informative. Very good information for our patients and their families. All right, well, I guess that'll do it for today then. Take care, everybody. Thank you.
Thanks, everyone.
Thank you, Dr. Lee.
Take
Bye.
care.
Thanks,
a lot.
Dr. Lee.
Thanks, Amy.
Thanks.
Thanks, Steve. Take care, guys.